Mm-hmm.
Could we start with Dr. Chavez? Would you tell me what do you know about the patient here in the Sacramento area currently hospitalized?
So we have been working very closely with officials throughout the state and local health departments in following up on the evolving Ebola situation. We have requested that healthcare facilities throughout the state be on the lookout for any patients that may possibly have Ebola infection. We have indicated to those facilities that if Ebola patients or potential Ebola patients are seen in their facilities, that they have to follow CDC guidelines for isolating these patients and for treating these patients. We are aware that in Sacramento County there is a patient that is being treated at a Kaiser facility. That patient has been evaluated by the healthcare personnel and by local health department personnel. That patient has been deemed to be low risk using a CDC algorithm for characterizing patients. Nonetheless, just because of the potential for Ebola and out of just being very, very cautious, blood was drawn from that patient and specimens sent to Atlanta for Ebola confirmatory testing.
Was there a reason why this patient was admitted? Why was this
Right. Correct. So this patient is a patient that traveled to one of the affected areas and had some of the signs or symptoms compatible with Ebola. So we've told healthcare facilities in those situations where you have travelers from those countries that may have symptoms that are compatible with Ebola, always exercise caution, isolate them until we can treat them, until we can diagnose them and make sure that we can rule out Ebola.
Doctor, you said travel to an infected area. Are you specifically saying West Africa? And which country did that person travel to?
Right. So we are saying West Africa. We cannot really provide any details on the cases because of confidentiality, but it was West Africa.
Why can't you tell us the name of the country on where this person traveled to? How will that help identify?
We are very concerned about the patient's right to confidentiality. Any information, including travel, age, gender, cannot be provided in respect of that.
Dr. White, can you tell us what should the public take from this? How concerned should the public here in California be about risk of Ebola coming to the United States from West Africa on an airplane with someone who is not yet symptomatic?
So the risk of Ebola in California and Ebola transmission in California is very low. We have a situation here in California where we have the infrastructure both in the healthcare facilities, in our public health system, in our general infrastructure with respect to sanitation that dramatically reduces the risk of Ebola transmission. As Dr. Chavez has said, we have been working closely with healthcare facilities and local health departments to implement a system of early identification and isolation of patients. I think the situation in Sacramento County has demonstrated that that system is actually working, that we had early identification of this patient, and that the healthcare facility and the public health authorities could take appropriate action. So I want to emphasize again that the risk of Ebola transmission in California is very low, and that steps are being taken to keep California safe.
Back to this patient, can you tell us a little bit?
Cases with respect to Ebola?
Can you please repeat your question?
Any other cases in California with respect to this Ebola isolation?
There have been no cases in California where there has been deemed to be a high risk of exposure to Ebola.
Any low risks?
According to the CDC criteria, this patient in Sacramento is the only low-risk patient that has been reported to the California Department of Public Health.
Can you clarify something that has to do with this question? On the phone or earlier you said that there are no other high or low-risk patients that you're worried about, but yesterday the CDC said there's a total of 10 tests that were being tested for the state of California. So are those not related, or are they already?
As far as we know, there's been only one specimen from California submitted to the CDC, and that's from the patient in Sacramento County.
How long
has this person been back in the country? When did they return to the country, and have they had interactions with other people? And is anybody else being warned that they may have come in contact with?
Right. So that's a very good question. Part of the containment of any potential Ebola cases involves obviously identifying cases early on, isolating the patient, but also in just as additional precaution, identifying anyone that may have been in contact with that particular individual. We do that so that if that patient eventually became positive, say for Ebola, we've already identified potential individuals that were exposed. Those individuals have been told of potential exposure and to look for potential symptoms. That is what we do normally with any infectious disease like Ebola, so that we can follow up with those patients if we need to.
Was this person in the public? I mean, was this person out and about? And again, how long is the person?
Yeah. Do you know when they came back?
This person has been back in the country since the first part of August, but I want to make an important point here. People who are well do not transmit Ebola, and so until someone actually becomes ill, there is no risk. And so in terms of exposures in the community, that's not really a concern, and we have, as Dr. Chavez mentioned, been working to identify those people who have been in contact with this patient since the person became ill.
How long was the patient in West Africa, and was this patient on a mission of some sort, or was he working with folks that are affected with Ebola?
We don't have that information.
Dr. Watt, can you address the blood samples, the protocols in terms of what was taken from this patient, what was sent to the CDC, and when you'll get it back?
So the CDC has a guidance for how to obtain specimens and exactly what specimens they need. They need blood specimens to be sent that they test using a test called PCR, or polymerase chain reaction. That's a test to identify the virus in the blood. So the blood specimen has been sent to CDC. We have been advised that it may take a day or two in order for those specimens to be returned, and we're waiting to hear the results from the CDC.
PCR is pretty quick. I mean, they can do it in hours, correct?
There are the test itself takes a few hours, but there are a lot of steps that are involved in terms of receiving the package, making sure it's properly accounted for, making sure they've got what they expect to get, making sure that it's appropriately and safely handled there at the CDC. They may decide that they need to do confirmatory testing. I really can't speculate on all the different steps that may be involved, so it's much more than simply running a test in order to get the results and get them back to us.
You said tell us a little bit about.
You said in the teleconference that you weren't surprised to find us here doing a test like this, but just now you said the likelihood of transmission in California is very low. I sort of want to drill down on a disconnect there. But how likely do you think it is at some point Ebola will wind up on our shores?
That's a really good question, and I think drilling down into that is helpful. The reason that we said on the teleconference that we're not surprised by this situation is that California is an international crossroads. People come here from all over the world. It's not surprising that people come here from West Africa. The other important point is that the initial symptoms of Ebola are nonspecific. They are similar to other infectious diseases. So again, it's not surprising that a recent traveler would come and develop these nonspecific symptoms. And that's what we've been really working with healthcare facilities and public health authorities around the state to be able to recognize that and take the appropriate steps. So that's the part that's not surprising. What we think is very unlikely and low risk is that any of those people will actually have Ebola virus disease. And if they do, we also believe that we will be able to effectively contain that and prevent any transmission from happening.
When was the sample sent to the CDC?
The sample was shipped from Sacramento County yesterday.
Back to the patient, can you tell us a little bit about the patient's condition as of today? And two, is this patient a California resident, or is this patient, was he just visiting, or she just visiting from the Western Africa?
We really do not have any information on the patient that we can share. I'm sorry.
Even an update on condition?
You need to talk to the hospital about that.
What are the protocols for shipping the blood? Do you send it out FedEx, or does it have to have special precautions?
Yep.
There are very detailed precautions that have to be taken for shipping any kind of potentially infectious specimens. Those regulations are determined by a set of criteria called IATA, I-A-T-A. I believe that's determined by the Department of Transportation. People, in order to ship those specimens, have to be specially trained, and so and there are certain shippers that are equipped to handle those specimens. So in shipping this specimen, I can tell you that those guidelines were carefully followed, and that they were shipped by a shipper that is able to handle it and transport the specimen safely.
What happens after, if this patient is deemed positive, what happens then? And if not, what else could this patient be suffering from?
Go ahead. Sure. Well, I think that the pathways would be quite different depending on the results. Our expectation is that this patient would be tested negative for Ebola virus infection, and that the patient will be managed according to the appropriate care depending on what that patient's doctors determine is needed. Should the patient be positive, in the unlikely event the patient will be positive, then as Dr. Chavez was describing, public health authorities would take steps to follow up on anybody who may have been exposed, to advise them of what they should be watching for and what they should do should they develop any symptoms, and giving them information about how to safely seek care.
Are those people already being seeked out beforehand? Are you proactively finding anybody that may have been in contact?
That
Yes.
is, yeah, go ahead.
Yeah, that is correct.
So you're actively seeking out the person, you're building that tree already, who that person may have been in contact with, that happens even before positive comes back?
Right, that's correct. It's best to do that at the beginning when we are able to talk to the patient and get all the information that we possibly can. And when I say we, I'm talking about public health in general, and this is being done primarily by the local public health department, identifying those people, finding out what their contact information is, so that we're prepared.
And let me just expand on that, because I think that's an important point. You know, to contain an infection like Ebola, it really requires two very key components. One is to have a very strong healthcare system that has the capacity to isolate patients and to protect healthcare workers and others from being exposed. But it also requires a very strong public health system that actually has the capacity to identify anyone that may have been exposed, so that they can do a circle of containment around that individual to avoid infecting others. In California, we have both a very strong healthcare system that has the capacity for isolation of potential patients, and we have a very strong public health system that I think is very good at isolating, identifying patients.
If I could follow up on that point, then say you do get a positive, say it's unlikely, but if a positive does come through, is the prognosis any better for someone being treated here in California or the United States than for somebody being treated in West Africa? Would we see the same fatality rates here that we would see there?
That is an outstanding question, and the reality is that the great majority of the experience in dealing with Ebola has happened in the setting of limited healthcare resources in Africa. And so we really don't know the answer to that question. What would happen when you have patients being treated in a Western healthcare environment? There was actually an article in the New York Times recently asking these very questions, and the answer is we don't know.
What were some of the symptoms that this patient displayed that raised the red flags where this person, you categorize this person as low risk for Ebola? What were some of the symptoms that this person walked into the hospital or coming to the hospital with?
Do you know that?
We have very little information, and we're not going to provide any specific details about this patient's clinical situation.
What is low risk? I mean, what constitutes low risk, if you can go over, as opposed to the high risk? What's the difference?
So there is an algorithm that the Centers for Disease Control has developed, and there are really three components to the algorithm. The first component is travel history. Have they been in a place where Ebola is present? The second component is, what have they done in that place? Simply being in one of those countries doesn't necessarily put somebody at significant risk of exposure. Have they had participating in any kinds of situations where they might have come into contact with somebody who's actually ill with Ebola? And then the third category is their clinical picture, and that's quite complicated. What kinds of symptoms do they have? Do they have symptoms suggestive of some other illness? What are their laboratory studies like? And so you put all of that together to do a risk assessment and come up with the probability that what you're looking at is somebody who actually has Ebola.